I'm delighted to be here to give you a little bit of perspective on my experience with what we as radiologists can do about these muscle injuries. I would say that my experience is fairly unique because we see a lot of professional athletes, and I think the main message you should probably take away is that by and large, these muscle injuries and even the higher grade ones are non-surgical and will be treated conservatively. So the interventional part is sort of provocative, and it's done for athletes that are getting paid a lot of money and are willing to go through the process of having interventions done. So the majority of things are treated conservatively with the typical medications and just sort of rest and relaxation. Surgery is fairly uncommon. In fact, it's quite uncommon unless it's a really high-grade injury. Most of what we deal with in imaging and what we can do as radiologists are these minimally invasive things like drain fluid collections, hematomas or seromas. We can inject medications, whether that be anti-inflammatories or the biologic things like platelet-rich plasma, which I'll talk a little bit about. We can also do things like needle things and cause inflammatory reactions that may promote a healing response. Sometimes referred to as prolotherapy. You can do like hydrodissection things to try to increase scar tissue or break up scar tissue. So I think it's useful to break down the anatomy by zones of muscles because different interventions can be done in different areas. So I just chose the semitendinosus here because it's sort of one of my favorite muscles. And it has two of each thing, but there's an origin and there's a free tendon component. The myotendinous junction is where a lot of the action is, as you've seen, and then there's the muscle belly. So if we look at the origin, what things happen and what things can we potentially do? Well, at the origin, we can have inflammatory change, whether it's in a sheath or not. That can be treated with corticosteroid injection, platelet-rich plasma injection. You can have tendon degeneration, tendinosis or tendinopathy that can be treated with tenotomy, needling the tendon, PRP as well. PRP comes up quite a bit here. And you can have the tendon be torn off the bone, avulsion. In that case, there's not a whole lot we can really do to fix it with imaging, but you can drain fluid or do injections. So a lot of these images are going to be similar to what my colleagues have shown, which is good because these disorders are common and prototypical. Here's peritendinitis around the iliopsoas. This can be injected. It could be in the bursa, but it's a little bit less well defined. So on sonography, the femoral head's here. Here's the iliopsoas tendon, and then you see a needle coming in. I like to follow the needle in longitudinal projection all the way down to the target and come down and kind of abut the tendon and then inject medication, which in this case includes some corticosteroid and mixed with bupivacaine. And most of these all mix with about 5 cc's of anesthetic, not so much for the anesthetic effect, but to be as a vehicle to spread out the corticosteroid a little bit further. Here is more of a complicated case in a 22-year-old runner where this young woman has bad tendinopathy, some internal tendon increased signal. You see the edema on T2 weighted images. There's peritendinous inflammatory change. There's probably some partial tearing. There's even bone marrow edema. This is a good example of a case that could benefit potentially from platelet-rich plasma injection, and that's what we've converted over to doing more so than our prior experience, which was with corticosteroids. So here's the MR image, and here's the image of the ultrasound, the ischial tuberosity with the little needle going in and fenestrating the tendon, kind of fanning out different areas. This is actually the diagnostic ultrasound, which you can see it's difficult to actually perceive the tendinopathy here. It's a little bit more echogenic in this component of the tendon. PRP is pretty controversial, and I wouldn't say that I think it's the end of the world and the most useful thing to do. But what it is it's taking the patient's own blood and spinning it down in a expensive special tube in a centrifuge and getting the platelets out, about 2.5 to 5-fold concentration. It contains all these fancy special chemicals like platelet-derived growth factor, VEGF, epidermal growth factor, all these things that supposedly help stimulate a healing response. It's the same thing we have in our blood natively, but it's just more concentrated because it is around the platelets. It's not covered by insurance or Medicare, so that's a big problem. Some places do cash payment. We don't do that at Stanford. A lot of different mixed results. I'll talk a little bit more about that in a minute, but the key thing is it's really difficult to know whether if you're needling a tendon and causing that inflammatory response to treat tendinopathy, if that's the main effect or if it's the PRP that you're injecting. And so it's really hard to know. Here's a patient who has a high-grade hamstring avulsion. We're kind of going into the sort of the free tendon area, actually still more at the origin. This tendon is, all three tendons of the proximal hamstrings are torn off the bone and retracted down. These are types of things that can be surgical, but surprisingly, even with this high-grade type of an injury, if it's not a real elite athlete, they may actually end up scarring down and having reasonable function later on. There's not much we can do for that. If there's fluid around, we might be able to drain fluid out of one of these areas of a free tendon tear, but for example, this Achilles tear with a gap, theoretically we could drain the fluid out of there, but it's not going to do this patient any good. This was a high-level athlete. This needs to be kind of sewn back together. In cases of non-distracted Achilles tears, it wouldn't be unreasonable to try PRP. Another kind of free tendon injury. Here's a high-grade tear of the proximal rectus femoris. You can see the gap here on MR coronal. Here's the ultrasound where you can see the fluid and the needle coming into the space here. And I think one of the benefits of the drainage in this case is that you can get these tendon ends closer together if you can get rid of the hematoma, and hopefully that'll help with the healing response. Moving into the MT junction, this is where a lot of the action is, right? We've seen all these different strains that occur of different grades. So you can have just the strain injury, or you may have the strain occurring with a hematoma, or you could have a contusion. And chronic strains can actually be painful for patients as well. So here's just a sampling of 6 different patients with all that feathery edema along the myotendinous junction, very similar to what Dr. Linklater just showed. Different muscles, very similar pattern. These are all like what would be intermediate grade injuries. And again, like the other speakers, I don't really grade these. I talk to my orthopedist and say, yeah, it's mild, it's moderate, it's severe, or it's completely torn, but we don't really use a grading system per se. This is a low-grade injury. You just see the vague edema, but really none of that fiber disruption. So there's really not anything that we would do for this interventionally. It should heal up quite nicely on its own. This is a higher grade biceps injury where he's a wide receiver, a professional football player that had this injury, just a little bit of myofascial separation here, fairly low grade, but a definite injury here in the distal biceps. He went back and played 2 weeks later and then felt it pop again. And so then he ended up with this scan showing this collection here, more fiber disruption here along the fascial surface and the collection there. So in this situation, what we do is we'll bring these patients to ultrasound. And one thing that's helpful to do is look with compression and see if the fluid is mobile. Then you can tell, yeah, I can get that fluid out of there. And once we get the fluid out, then we'll inject typically with PRP. Now you could argue patient's own blood is already sitting there. The PRP, does it really do any good? It's actually really hard to know, but we get it. But that's what we do. So this is the fluid that was removed. A different patient, another pro football player, sagittal image. Here's the axial image here. If I can, let's see if I can stop this. It's going to be scroll up. You can see that along the central tendon there's some little foci of hemorrhage, the low signal, and edema. And it's a kind of another intermediate grade injury. This will heal nicely on its own. So if that's you or me, it's just like take it easy and it'll be fine. But for pro athletes, we'll go in and we'll find the area of the tendon and the hypoechoic injury area on ultrasound, and then use that image to guide an injection down along the myotendinous junction. Now, in the past, I used to use a lot of corticosteroids in these, and it's controversial because if you get an infection, that could be a disaster. Luckily, I never had that happen. So now we're really transitioned over to using PRP for those types of injuries. One thing that's just a pitfall is you can see the sciatic nerve is in the neighborhood of these types of thigh muscle injuries. So here on the long ultrasound, you can see the tendon here of the biceps. Deep to it is a sciatic nerve. It sort of almost looks like tendon, so you have to be sure if you're going to do an injection, you don't go and inject right along the nerve. So this is a little bit tongue-in-cheek, but here's all the factors that go into whether PRP works or not, okay? And I kind of made this up, so you can take it or leave it. There's 3 different components of the efficacy. One is the injury-related efficacy, and that has to do with what tissue is injured, what's the location, how bad is it, and when did it happen. There's also what I would call therapy-related efficacy. Do you use image guidance? Who made the kit? What's the platelet concentration? Is there white cells in it or not? Did you dry needle the thing? How much local anesthetic did you use? How did you rehab the patient? Did you repeat the injection? What other treatment were they getting? Then there's a sociological efficacy. Sorry, the lines are like our Microsoft moment here, but how much did it cost? Did they have to pay out of pocket? Did they comply with rehab? How competitive? What are their expectations? What does the agent think? What's the team standings? All these things actually go into the efficacy of this treatment. And so it's very, very difficult to know the bottom line because all these things are different. So here's the bottom line is the compound efficacy is injury related versus treatment related versus sociological. And it's like, I have no damn idea if this stuff works or not. Okay. I like the semitendinosus, and one reason I like it is because it's kind of a sinister character if you get injuries in this location down behind the knee, because what seems to happen is patients get a lot of scar tissue formation, and they can end up not healing this well and end up with chronic pain. So in these instances, we've been sort of aggressive with trying to get medications injected along the semitendinosus down here, as it's sort of superficial to the membranosus deep down. And it's known in football, for example, that these semi-T injuries, they actually don't do well with non-operative treatment in general, especially the high-grade rupture. So this is why you hear about patients with this tendon, and you can sacrifice this tendon. We don't need it. It's used for ACL reconstructions and things like that, so you can take it out without loss of function. That surgeons will go in and cut it out after it's injured. So in this athlete, it wasn't a complete rupture, but you could see the edema around the tendon. Here's the pre-ultrasound, and here's where we injected the fluid afterwards. And this medication actually settled her right down, and she was able to get back to play within a week or so without long-term consequences. As David showed, you know, when you have somebody that says, I felt a pop, I think that basically almost always tells us that something is wrong, right? Or if something tore, like a tendon tore, a muscle tore, the pop is a notable thing. So here's another football player, and it's very similar to the case that Dr. Rubin showed, the tendon coming down and interrupted right here, hematoma deep to it. So here's one section, and we'll go down, and then now we're lost the tendon. Let me just see if I can go back one. So here's tendon to that medial gastroc, and you go down, no tendon. So that's a big broad tear, and then you come back down further and you get the tendon again. So that's another case that would be amenable to treatment, although there's not a whole lot of fluid there. Now on this video, I'll see if I can control it here again. As you scroll up and down, you can see, like, here's the muscle, here's tendon here, and as you go caudal, I think you can probably see, I can't point at the same time, but the tendon disappears, and then you get into this hematoma. So if you're scanning with ultrasound, you have to be very systematic, and I find that ultrasound is really tricky to do, so that's why we do so much MRI. Again, draining a little bit of fluid, injecting with PRP in this guy because he's a pro athlete. Lastly, the muscle belly. There's not a lot that we do there except drain collections, and that can be significant for either strains or sometimes contusions. Here's a pretty high-grade tear of the biceps in this patient with a small hematoma that could be drained. Here's a nice big quadriceps contusion in one of our Stanford players. And here's a good example of using compression on the ultrasound to say, oh yeah, that really squashes around. We'll be able to get that out pretty easily. And so we drained him 100 cc's one day and then 90 cc's 2 days later. Big hematoma in the biceps in the arm, big echogenic collection here, drained out I think 90 cc's or 70 cc's from that. So that can definitely decrease pressure and help patients feel better. I wrote up our experience, or we did in a couple of years ago in American football, all the hematomas that we drained. And a lot of, quite a bit of volume, like pretty big volume, 70 cc's. The biggest one was 600 cc's. That was a big Moral Lavallée kind of lesion. Hematomas due to strain injury tend not to have as much fluid as sometimes the bigger contusions and things. This is a contusion, more of a direct blow in the quadriceps, and it's heterogeneous. You can see it's ovoid collection. Ultrasound showed that it's very echogenic, and so even though I tried to get fluid out, none was able to be retrieved because it just wasn't liquefied. And again, I wouldn't try that on non-professional athletes, but he wanted me to do it. Here's one that's kind of intermediate. So there's the collection here, just in the vastus intermedius, partially compressible. Tried to drain it, got a few cc's out, but not a huge amount over time. Here's, you've seen this example before, this entity of this this irregular collection along the deep thigh here, and draining fluid out of that. I got 3 different times, got fluid out. Ultimately, the last time it started to form all the shadowing on ultrasound, and that was, of course, development of Myositis Ossificans. Last case here, I love this because it's another football player as an abdominal injury. He actually got kicked in the side on a kickoff. He almost had to like remove the shoe from his abdomen. But draining out this hematoma in the abdominal wall and getting the muscle fibers closer together. And he actually went back and played the next week. So to summarize, I didn't really talk a lot about diagnostics, but the MRI is a lot more sensitive than ultrasound is for the low-grade injuries. We do offer good potential for therapy with our image guidance techniques, and it depends on the clinical setting and where the injury is located. The efficacy of these things is not really well established, but it's something I think we can offer to many of our patients. So thank you so much.